Let me introduce Ruth Carrico. So Dr. Ruth Carrico is Associate Professor and Family Nurse Practitioner with the University of Louisville School of Medicine, Division of Infectious Diseases, and Founding Associate Director of the School of Medicine Global Health Initiative. Dr. Carrico has served as an editor of the APIC Text of Infection Control and Epidemiology and on the APIC National Board of Directors. She was president of the Certification Board of Infection Control and Epidemiology, CBIC, in 2016, responsible for board certification for IPs worldwide. She's also editor of the University of Louisville Journal of Refugee and Global Health, launched in 2016. So, now that we've got the slides working, over to you, Ruth.
Thank you. Jonathan, thank you for that nice introduction. It shows that I'll do anything to keep from cleaning my house, right? Just stay busy, keep on moving on. I'm happy to have the opportunity to be with you today when we talk about an issue that is really taking a rapid growth in our consciousness about the many issues about infection prevention and our responsibilities to our patient. Please remember, every time we have an encounter with the patient, we establish a relationship, a covenant. And that is, we're going to do the best for them every time at every encounter. And when we do that, it requires that we take this notion of a complicated issue or a complex problem. And people ask me, well, what's the difference between complicated and complex? And I always say complicated was sending a man to the moon and then bringing him back, right? Making sure that we could repeat those same steps. Complex is raising teenagers, right? You can have two kids, same situation, but there's so many differences, right, that come up with each time you encounter or have anything to do with those teenagers. And so I look at these issues as a complex issue because how we use ultrasound, under the circumstances, all the things that can happen can change so dramatically. And this means that we have to then bring in a systematic approach to the use of these devices if we're going to keep that covenant with that patient, that every time we encounter with them, that it will be a safe one consistently. So I want to kind of take you on a journey where we have been in the United States, because so much of what you are doing here shows that you continue, as I would tell my infection prevention colleagues, you're one step ahead of us. You're seeing the issues, you're really addressing the issues head on and with a thoughtful approach. So I'll kind of take you on the journey where we have been in the U.S., where we are, and I'm so appreciative that our neighbors to the north are making it easier for us because we have then some reference that we can then refer to as we try to improve practice ourselves. So many of you are familiar with the Joint Commission, or TJC. They used to be called JACO in the past. That is our primary accrediting body, not the only one, but the primary one in the U.S. that is responsible for ensuring the safety of all patients in every setting where healthcare is delivered and is accredited. So we saw this information from the Joint Commission in 2017 that said, hey, we are recognizing that we have some issues with how reusable medical devices are being managed and the hygiene or the practices that are occurring with these devices. And it showed then, when they did some retrospective looks, it showed that this problem had been present and recognized for a number of years. So as we have begun our approach in improving practice, we've kind of picked the low-hanging fruit. But our rates are still not at zero. Therefore, we know that there is some fruit that has been hidden in the trees. And the Joint Commission has said you really need to be looking more closely at these devices that are used across your patient settings. At the same time, you were seeing these same issues. We've been seeing these same issues in Europe, across and around the world, all that are identifying some problems with patients. And this is just an example of something more recently that has happened in your neck of the woods, where we saw some exposure to patients, sexually transmitted infections at a fertility clinic, and then some lapses in infection prevention and control were questioned. This involves some inconsistencies, both in reprocessing, but also how do we monitor what we are doing? How do we track so that we can identify when we have problems and then reach back to patients? And just like in the U.S., we always have those that are eager to take advantage of what our failures may be, and that you then saw some resultant lawsuits. Now, we never want to change practice solely because of a lawsuit, but the lawsuit certainly keeps us honest, doesn't it? It reminds us that we have an accountability. We have that responsibility, that covenant to our patients, and if we fail to meet that, then there will be someone there that is going to remind us, and the strongest reminder, unfortunately, comes through our pocketbooks. And in this instance, then the facility was asked to temporarily stop performing some very important procedures on their women patients in the fertility clinic. So this was a tremendous issue for this place. So, we remember that it is critical that we understand what is happening, and a lack of knowledge or ignorance of the process does not protect us. This becomes even more important when we look at the explosive use of ultrasound across settings. And we are using ultrasound for a number of purposes. And I was talking with someone the other day, and I said, gosh, I remember I've been a nurse for over 40 years, and I remember that really our first ultrasound issue was that little Doppler that we had, that little pencil Doppler that we would use and then stick up in the cabinet and never think about wiping it off. And maybe if it got all hairy or something, we might wash it off. I know, that's disgusting. Sorry, over breakfast. I know. Oh, sorry, I know. But that was the reality, right? It wasn't a matter of disinfection. It was just, hair removal. And that we just felt that it was just not very aesthetically pleasing to take that to the next patient. But now we have seen then ultrasound that is being used in every place. And we know that because it's such an easy procedure to use and has so many purposes, we will continue to see its growth. We will continue to see its use more in new ways, things that we haven't even considered. And this slide just kind of shows a portion of the spectrum for ultrasound use, those uses that are requiring high-level disinfection or sterilization. So think about in your facility. I bet if I ask you to list all of the procedures, you might make it to maybe 30 or 40, but when we start really looking at the numbers of procedures, we are close to 100 and probably beyond. And as with anything, in my old age, I've learned to use YouTube. If I want to know how to change a light socket or something, I go to YouTube. So it's interesting to go to YouTube and see how is YouTube being used to educate, to train others regarding the use of particular types of medical devices. So I would tell you, don't eat before you go to YouTube, but I would encourage all of you to just spend an hour or so and float around and look at the demonstrations, the visual demonstrations of ultrasound use across a variety of procedures and specialties. This, I think, is a huge red flag for us, because most of the time, unless you're going to be on Facebook, nobody's going to put a video of somebody doing something wrong, right? Only on Facebook, now we think, right? But YouTube, this is what people think is right. So they are promoting their procedure. So look at what people think is right, and this is the how-to guide that others are going to use when they are trying to learn a procedure. And remember, if we don't tell the whole story, people make it up in their minds. They put their existing knowledge into play. And I always, tell people about this story. I walked in to one of the areas at the University Hospital one night, and I saw just the sweetest little medical student sitting at the desk at the nurse's station. He had a stack of alcohol prep pads that he had opened, and he had a bronchoscope just laying on the nurse's station. I'm like, what you doing? And, and in my mind, I'm thinking, please no, please no, please no. And he's like, I'm cleaning the bronchoscope. And I'm like, oh, and so his resident told him, here, we took it from the OR. I want you to clean it. We'll put it back. Nobody will ever know. And so in his mind, he's like, well, we use alcohol prep pads for everything else. That must be what I'm supposed to do. So he thought he was doing the right thing. So as we think about our approach to ultrasound, please remember that your staff are going to do what they think is the right thing. And our approach has to be, how do we prevent them from doing the wrong thing and enable them to do the right thing? And so when we think about these systematic approaches for the care of our devices, it becomes more important that we begin to think, all right, where are those places that we can remove error and enable people to do the right thing. And when we look at the number of opportunities to do the wrong thing, look at all of these different types of procedures, and these are just a few of the list. The people that use the devices, the places they use the device, and the actual use of the device themselves. So again, as we go back and we think about the complexity involved in this, how in healthcare do we deal with complex situations? We make the rules simple, right? We try to make it easy to do the right thing. How do we then enable people to give their patient their best? So I look then at the standards that you have. The recent, to me, March is still recent, 2018. As long as it's 2018, that's still recent to me. And it looks at then your standards, look at the integration of a number of reprocessing standards, which Chapter 13 focuses specifically on ultrasound probe reprocessing. So you've already taken this major step that many of us are still struggling with, and still we just don't have consensus among a number of our society and national guidelines. So it's nice to be able to reference our neighbors to the north. The standard then sets then the requirements for medical device reprocessing by using the Spalding classification. And this really has been, for the last 50 years, this has been our go-to framework for helping us decide what is the device going to be used for, and then recognizing the outcomes that can occur from poor use, how then do we manage it? So it's a very, very simple process and a framework to follow. And it reminds us that, it's no fair saying, well, I like it for everything except this, or this doesn't suit me, or it's hard, or whatever. This is a standard framework that not only can we use to train, but we can use it as part of our performance measurement. Are we doing this? Are we getting it done? It gives us then very specific standards that we can use for process assessment and then process improvement. It's so clear and logical that its use is pervasive. And although I never like to think of any document as being authoritative, I consider the Spalding classification really to be the authoritative document on reprocessing. So when you look at and you kind of look at how that document is formed, the device itself, its purpose, and what it may contact is on the left. The triangle in the middle then shows, well, how then should we approach that device in terms of its reduction of microorganisms and therefore its opportunity to cause illness or harm to our patient. And then what happens to those microorganisms? So what is the efficacy spectrum? So it makes it very easy to follow. You think about, what do I want to achieve? What am I going to do with this device? How should I process it? And then what should I expect from processing that device in that particular way? So in your standard, just looking at one standard at critical and semi-critical and non-critical care of devices, it's all very clear. It's been outlined very well and follows Spalding really to the T. So for example, a critical device is an ultrasound transducer probe shall be sterile when it enters tissue, the vascular system, sterile body cavities, and where a biopsy is being performed or considered. And I want to kind of take you on a little mental picture right now. So if you are undergoing a procedure and you have a needle, and that needle has to pierce your skin, and you have the ultrasound probe that is going to be near or touch that needle. When those two elements come together, you want to make sure that that needle that is going to be placed inside your body is not contaminated because of the care you have taken or lack of care you have taken of that device. So the actual needle itself, or the catheter or whatever that may be introduced into a vein or introduced into an artery or elsewhere in the body, if you touch that before it is introduced, then you offer opportunity for that device to be contaminated. And we all know then the sequela. We recognize the issue of one microorganism becomes many, many then become a colony that may be covered and protected by biofilm, and then we have a continuous cascade of negative events. So we want to prevent that when we can, and again, we want to prevent that consistently. So anytime you have a question about practice, to me, the best place to start is to say, Where are we in this journey? What is our existing practice? And if we're going to change practice, let's know where we are, because then we'll know how well we have done in our changes. So we decided then to undertake a survey. So a group of colleagues and I got together and said, we really need to ask our infection prevention community what's happening, because the infection preventionists are responsible for looking at outcomes and then being able to trace back risk factors and then determine what needs to change in our facilities so we can, again, protect our patients every time and with every encounter. So we put together a survey, sent it to about 13,000 infection preventionists, and asked them to tell us about their practice. We were very fortunate and appreciative that the costs associated with the survey were achievable by a research grant from Nanosonics. Everything was anonymous, so we asked them, just tell us, without trying to influence practice at all, we want to know what you're doing. So that gives us a starting point about how well. Well, and we found some answers that we knew. We knew ultrasound was used everywhere, but ultrasound is literally used everywhere. It is in every department. There is some purpose for its use in every department. Every department does not use it the same. Every department does not view the risks the same, unfortunately, and that there are certainly opportunities for improvement. When we looked at some of the results, after they said, okay, this is where we use the devices for, then we began to ask them, well, tell us how well, or tell us your adherence with these standard approaches for reprocessing. So again, we provided scenarios to say, how do you respond without saying this is right way, this is wrong way, according to Spalding. Tell us what you are doing. And so when we look at then these invasive procedures, when the probe is considered to be critical, if you look then at the graph and look at the blue bar, these are the percentages of time when the reported practices were outside what we would expect from when we follow the Spalding classification. Now, some of you may live with your glass half full, and you're like, great, for intraoperative scans, 85% of the time. To me, when it comes to infection prevention and control, my glass is half empty, because I'm focusing on 15% of the time we did not follow the correct procedures in a surgical setting. That to me is an issue, because I always look at the OR as the mecca for surgical conscience and the ability to maintain a high level of infection prevention, just because they have very rigid and long-standing specific methods and standards. Not so outside the operating room, and I think many of you will agree with that. But then let's look at what was happening when other device uses were involved. For central venous catheter insertion, only 27% actually reprocessed the device within the suggested classification. So we had a lot of variation that occurred. So to me, this lets me know that right now there are two things. When something doesn't happen correctly, it's either because people can't or they won't. So we've got to figure out how, and then sometimes there's a little bit of a mixture. If they won't, my perspective is because they don't understand the why behind why they must be in adherence. And if they can't, then what are the systems barriers that are keeping that from happening? Not enough equipment, processes not in place to support, not enough personnel, or whatever that involves. That's what we need to better understand. When we looked at when the device was assumed to be semi-critical, we did pretty well with endocavitary scans. Again, only 7% were not adherent with Spalding. But when we look at the use of scanning across non-intact skin, we had a lot of variation, about 50-50, right? Half the time we do it correctly, half the time we don't do it correctly. I don't know about you, but I really want to be on the side of that, do it correctly, right? And I feel a sense of urgency. Now I'm officially at, I don't call myself old age. I think I'm either a classic, like a car, or vintage. But the older I get, and the closer I get to being on the other side of the bed rail, it takes on a different level of significance, doesn't it? I know, but it does, and I'll be the first one to say, so I become a little bit more anxious about this. But it brings to mind then, the only way that I know staff can be successful is if we have standards and if we have standardized approaches that minimize the opportunity for variation. When we look at the opportunity and when we should see sterile gel being used, you can see we're all over the place. And one of the biggest areas of discussion right now is the use of ultrasound and when we are inserting peripheral IVs. That is a procedure that is performed very frequently. Little measurement has been done about problems, and if I've heard it once, I've heard it 100 times. Well, we don't have any evidence that it's a problem. And you remind people that absence of evidence is not evidence of absence. That just because you didn't look at it doesn't mean it isn't occurring. And this is not a game of hide and seek, right? This is one where our responsibility is identifying issues and then trying to bring solutions to the forefront. Now, when we ask then the survey respondents, well, tell us then about what you know about some outcomes. Are you aware? 20% were aware of issues where there had been inappropriate processing of the probe. Now, this is important because I think about how poor our responses were in understanding what Spalding says, and still 20% had issues with concerns about appropriate use. So to me, this is much more magnified than just a 1/5. This is 1/5 of on top of the numbers that clearly demonstrated a lack of knowledge and adherence. A little less than 3% were aware of situations where the probe itself had been implicated in some type of adverse outcome. We saw then reported failures when people were telling us where they did procedures, where it happened, what occurred. We saw then the impact across all settings. And then the staff training, everyone began to, and I think as you take a survey, and it starts off pretty well, I can make it really easily through the demographic questions. I know my gender, I know my age, I know how many beds are in the facility. I'm feeling pretty good about this survey. Then you start asking me, what I do, and then what should I do, and then the questions become a little bit more pointed, then I become a little bit more insecure, and I think that's what we saw, because at the end of the survey, we were seeing then a number of responses saying, yeah, we've got to improve our staff training. And this is interesting because 66% of those respondents believe that their policies need to be updated, and 92% preferred standardization of processes, and 93% preferred a reprocessing automation of some sort. This really supports then what you have included in your standard regarding not only an approach that is systematic, but also a linking of policies to enable, and procedures that enable people to do what is outlined in those guidances. So at the end of the day, this is a reminder that when we are dealing with complex situations, when we are dealing with problems that are new to our thought process and want to require us to consider new approaches, we've got to pull together teams. This is not one individual's responsibility, but we need to be have a mechanism where we can keep our finger on the pulse of the use of the devices, keep our finger on the pulse of how they are being handled and managed, who has responsibility, and does our system then support this? And the only way to make this happen effectively is bringing together then the people that have a skin in this game. And with ultrasound use and reprocessing, we know key players are going to be those that are responsible for reprocessing, those that are responsible for infection prevention and control monitoring and outcomes measurement, and then those that are actually using the devices. So pulling those groups together to figure out how well are we doing, what are our opportunities for improvement, and then where do we need to go in the future. So as we look at then our first few moments together before I turn it back to Jonathan and then to Rose, I want you to consider that in this survey, our data showed that we've got tremendous variation despite having a standardized framework in place for us to go to, that people don't understand. Many, I'm sure, users of ultrasound throughout the healthcare settings don't understand what they should be doing. If they did, I think they would make steps in doing so. So our job is to make it easy, again, for them to do the right thing and difficult for them to make mistakes, because ultimately it is the patient outcomes that are the most important to us. We saw compliance or higher levels of compliance in those areas of practice where they have a devotion to standardized approaches. And so much of, and when I describe these issues, and I'll say, you know, we are used to in the operative setting, if we have all of our instruments out in the OR and we don't use those that are on the back table, they've been totally out of the surgical field, but at the end of the case, we look at them as being contaminated, and we reprocess everything. When we enter an isolation room, everybody should be wearing isolation garb. That is our standard. We need to bring that same level of standardization with the use of a piece of medical equipment that could alter in its intended use during the middle of an individual procedure. You think you know its use, but then something happens with the patient because of the complexities involved in healthcare. And so we have to then have a process where we enable compliance with its care. A majority of the probes, as we looked at our survey results, a majority of the probes still did not achieve the level of disinfection that they should achieve. A lot of concerns regarding the use of not only gel, sterile gel, but also sheaths, and using a sheath instead of reprocessing a device appropriately. And that our inability to have some consistent guidelines, I think, is a challenge for us. In the U.S., we have a lot of flip-flopping that, well, you know, we want to reprocess using Spalding, but maybe we shouldn't for this purpose or that purpose. It's one of these things where, you know, when it comes to patient safety, you're either all in or you're out. You're not partially in. And so having then guidelines that are very specific and succinct as the ones you are developed, I hope will be a guidance for not only the U.S., but really the rest of the world to say, how are we going to approach this effectively and efficiently, and in a way that enables us to keep that covenant with our patient of giving them our best every time, every encounter.